Carter-Jenkins Center will present today a lecture entitled The Management of Attention Deficit Hyperactivity Disorder in Patients with Comorbidities, New Knowledge and New Warnings. And there you have the person that is talking to you. Here you can see in the short general introduction we are going to do about ADHD, this interesting kind of slide that says that a picture is worth 1,000 words, and you can see a mother very worried with a child that has an attention deficit disorder and had absolute chaos in his room. Everything is thrown everywhere. He's wearing a shoe box as a hat, he's banging on a pot, and so it goes. This is typical of children with ADHD, particularly boys at the young age. Here we are going to discuss some of the myths. One is that it only affects children, not adults, that it disappears at puberty, which is a myth. It doesn't happen, that children will grow out of it, which frequently doesn't happen, or most of the time really doesn't happen. That is due to too much sugar or to certain type of foods or colorants or due to fluorescent light and allergies, psychostimulant may used to using drugs. These are all myths that are very common. Now the truth is that it is a genetic disorder that runs in families, that is present during adolescence and adulthood. Now ADHD is like a table. The first leg represents the attention problems. The second leg, the hyperactivity problems. The third leg represents the impulsivity problem. And the fourth leg, the irritability problems. The combination of these different elements in the clinical picture is variable, and one or two of the legs may be missing occasionally. So there you have. Now we are going to talk about the medications and the danger of priapism. But recently the Federal Drug Administration has issued a warning for this rare but serious side effect. The average age was 12 and a half years of age, and the range was given at between 8 and 33 years. It occurred with increases in the doses of methylphenidate, or at times when medication was temporarily stopped for a short period of time, or when there was a longer period of time between doses than was typical for that particular patient, or sometimes after stopping the drug permanently. Seem to be more common in patients on stratera, atomoxetine, than in those taking methylphenidate. Erections lasting more than 4 hours require immediate attention to avoid damage to the penis. My experience with this problem in my patients is nil. I have seen during many years of my practice while I was director of the ADHD clinic at the University of South Florida, I never saw a case of this type, but apparently now they are taking place. Perhaps the reason was that I didn't tend to use a lot of Stratera, and this seems to be the medication that tends to pose the problem. The question of the appetite is lost with psychostimulant, and the question is, what can you do with it? And here you have some suggestions. The appetite is decreased while the medications are on board. How long depends on the half-life of the medication being used. For example, Concerta tend to last 11 to 12 hours, but other medication lasts less. The solution is increase the breakfast, add milkshakes, hamburgers, pizza, and things of that type, and give a late dinner. So the medication, if they are in the 12-hour medication, would have been gone by then. And add a snack at bedtime, allow supplements like protein shakes, nutrition bars, and things of that type. Where physicians tend to fail and why? Frequently, they don't titrate as high as is required, but this has to be done with much care. Do not do it by way, but by elimination of symptoms and or appearance of side effects. 35 to 40% of patients may need as much as 108 milligrams if you are using Concerta in the morning. At least another 25 to 30% of patients needs only 72 milligrams. And all the above applies to both children and adults, boys and girls. Doses can be increased every third day, by which I mean you start at a lower dose. Let's say you're using Concerta and comes in 18, 26, 27, 36, and 54 milligrams. You start with 18 milligrams for 3 days, then you may go to 36 milligrams. If that doesn't solve the problem for 3 days, and then you can go to 236, which is 154 milligrams. And if that doesn't solve the problem after 3 days, you can go to 72 and so on. You increase gradually, taking into account, as I said, the symptoms and the appearance of any side effects. Of course, you would have taken care that there are no problems and things of that kind in these patients. Remember that most psychostimulants are claimed to be full-day medication and not really so. They last mostly between 5.5 to 6 hours, and in some cases even less than that, which then means you have to give more than one dosage for the medication to do the job. And you need to remember to talk to parents about the loss of appetite and the things that you can do about it. ADHD is a genetic disorder that has many negative consequences, and you can see them here. There are more addictions and substance abuse if there is no treatment of the condition. There are higher divorce rates. There are more work problems. There are lower academic achievements. Generally, people with this disorder as adults will have a lower socioeconomic status, and there are more accidents of cars and violations of traffic and things of that kind. Let me tell you what I have learned in the many years in which I have treated this condition. ADHD is really a misnomer. The word deficit seems to imply that they are lacking something. In fact, what they are is hyperattentive. In other words, they pay attention to everything, to every stimulus that is produced around them, including even smells. They cannot ignore anything that happens around them, including, as I said, the smells. They cannot ignore any stimulus. The world is full of stimuli surrounding you everywhere. Think of a classroom with 30 students. If they are hyperattentive, that of course will lead to a lot of distraction. People with Down ADHD can raise the threshold for stimulus so that they can ignore what they do not need. They hear it or see it or smell it, but they do not have to go there. They do not have to follow every stimulus. Doing that is, of course, extremely distracting and takes ADHD patients away from staying where they needed to be. And that's why ADHD patients cannot stay focused on what they are doing and cannot maintain their attention on any given subject. Comorbidities complicate the ADHD treatment. The management of uncomplicated ADHD is usually straightforward. Stimulants are among the first line of treatment. Persons with ADHD often experience comorbid psychiatric conditions. Comorbid symptoms may alter sometimes the response to a stimulus. This is in terms of comorbidities as defined in the diagnostic manuals, be that number 4 or 5. But as important or more important are some consequences of having ADHD for the development of the personality and the character structure that will influence and change the quality of the life forever, though there is not an entity, a comorbid entity defined by the DSM manuals for these disorders. What I mean is, for example, these children, of course, they have these problems, don't do well at school, and frequently think that they are not very intelligent, or they certainly cannot do well academically, and consequently they lower the goals, the ego goals in terms of what they want to do or what they want to be and things of that kind, and end by perhaps going into an activity for the rest of their lives that is well below their capacities and will lead to a very much lower economic status. And so it does affect the personality, the self-esteem that people consider, important. And in their case, it's very, very low in many cases. And all of that, of course, changes the quality of their life very significantly. So these things that are not necessarily described as a comorbidity, but things that influence the development of the human personality and the character are not just as significant and as important, are not defined as comorbidities, but it's the same like we described a moment ago in terms of the increased number of accidents and violations of traffic and problems at work and problems in their marriage leading to divorce and things of that kind. These are the comorbidities that are reported in the MTA study. It's a group of 579 patients. Conduct disorder was in 83% of these cases, so the percentage was 14.3. Oppositional defiant disorder, very common. The number was 271, and the percentage of this disorder was 39.9. Then you have anxiety disorders in a high number, 194, making it 33.5% of the cases. Tic disorders are common. There are 83 cases of it for 10.9%. Affective disorders, there were 22 cases with a percentage of 3.8, and mania and hypomanic events, the number was 13, and this is 2.2. These are, of course, two different disorders, and you can have ADHD and manic or hypomanic disorder, but they may happen together. The stimulant treatment in ADHD effectively improves the core symptoms and the associated impairments of the disorder. Certainly improves the inattention, tends to control the hyperactivity, which is common, the impulsivity. It improves the peer and family relations, and it certainly improves the scholastic performance and the academic outcomes, whether it is children or adults. And let me tell you, it's not only children that have problems, academic problems. I have seen adults in law school, medical school, that were not functioning properly and could possibly not have finished their studies if they had not received the adequate treatment. Once you treat them, they may even go to the top of the class. They tend to be very bright. Now, these are the practice parameters of the American Academy of Child and Adolescent Psychiatry for use of stimulants in patients with ADHD and comorbidities. According to the American Academy of Child and Adolescent Psychiatry practice parameters, when a patient presents with ADHD comorbid with any of the following disorders, stimulants may be used for the treatment of the ADHD symptoms, that's the inattention, the impulsivity, the hyperactivity, etc. And this is true of the following: the oppositional defiant disorders improve very significantly. Actually, when the ADHD problem is treated, in fact, this type of behavior may disappear altogether. The conduct disorders, similarly, and of course the learning disorders, will tend to disappear once they can pay attention and they're not hyper and not impulsive. The oppositional defiant disorder and conduct disorder, children with ADHD with and without oppositional defiant or conduct disorder had an equal response to stimulant medication in the MTA study. And not only they improve, as I mentioned, in terms of their ADHD problems, but the oppositional defiant disorder and even the conduct disorders may significantly improve as well, or disappear altogether actually. At the University of South Florida, where I ran as well the inpatient units for children and adolescents, a common admission syndrome was either oppositional defiant disorder or conduct disorder. And when we studied the children, more commonly than not, we found that they had ADHD, and if you put them into medication, gave them medication for ADHD, these disorders tend to disappear as well as the ADHD symptoms. Here you have a little slide that shows a response in patients with ADHD and oppositional defiant disorder and conduct disorder. So that gives you an idea of how that kind of works. In terms of the learning disorders and the attention deficit problems, in subjects with ADHD and comorbid learning disorders, early intervention is important. Obviously, you avoid then what I was referring to earlier in terms of the damage to the self-esteem and the lowering of the goals for the future, or the academic interest, what they think they can do, or what they think they can, devote themselves to and so on. And that is, if it is not done early on, early enough, and the damage to the self-esteem takes place, this will last a lifetime, which is really a great pity, because it reduces the quality of life of these people and the level at which they can function. So early intervention is important, and the disorder often overlaps with various indices of academic underachievement during childhood and adolescence, and even in adults. By adolescence, comorbid learning disorders are clearly associated with school failure, significant school failure most of the time. The treatment improves not only the ADHD symptoms and school performance, but the learning difficulties are a little more difficult to improve, particularly when these have been going on for some time, because learning is cumulative, and if you lack the basis, what has to be built on top of that basis is checked, to say the least. But the school performance will significantly improve if you start early on. Comorbidities are frequent in patients with ADHD, so you need to be sure to look for them. The ADHD symptoms are the same if they are comorbid conditions or if they are not. The medications are effective in treating the ADHD patient with comorbid oppositional defiant disorder and conduct disorder. And remember that these two comorbid disorders tend to improve as well as the ADHD improve and get the appropriate treatment. Some additional safety information that you need to take into account. Use ADHD medication with extreme caution in patients with psychosis, bipolar disorder, history of seizures, EEG abnormality, and hypertension, or other type of heart difficulties. ADHD medications should not really be used in patients with pre-existing severe gastrointestinal narrowing, known structural cardiac abnormalities, or other serious heart problems, as I just mentioned. Stimulants may cause new psychotic or manic symptoms. Discontinuation of treatment may be appropriate in such cases. Aggressive behavior or hostility should be monitored in patients beginning the treatment. Methylphenidate is a medication that may produce difficulty with accommodation and some blurring of the vision in some people. Hematologic monitoring is advised during prolonged therapy with this type of medication. Methylphenidate should not be taken by children under 5 or 6 years of age. Growth should be monitored as well. Patients do not gain weight as expected commonly when in this treatment, and they may have to have the treatment interrupted, or this has to be watched very, very closely. Though in reality, in terms of growth, the study seems to demonstrate that this is not a problem. They shouldn't be used in patients with severe depression, schizophrenia, or suicidal tendencies. They are contraindicated as well in cases of angina pectoris, cardiac arrhythmias, heart failure, recent acute myocardial infarction, or in cases of hyperthyroidism or thyrotoxicosis. Psychostimulants should be used very cautiously in patients that have high blood pressure. Blood pressure in such cases should be monitored regularly and carefully. Clear communications on side effects, potential dangers, and the like have to be established between the parents, the patients, and the doctors, so as to achieve a proper informed consent. Mixing alcohol and methylphenidate seems potentially dangerous, and there have been sometimes serious problems with it, so it should be not done. Let me tell you what I prefer the medications that last 12 hours. If effective for 12 hours, children do not have to leave the class to take another dose at midday, which, it is a problem, kind of shows to the rest of the class having problems, and leads sometimes to inappropriate behavior by the other children to the ADHD child. The school doesn't need to be involved when you use a 12-hour medication, and it is strictly a family business. Schools do not always understand the need to overlap the medication appropriately when you have more than one dosage. And in the gap between the two medications, of course, all kind of problems may take place in behavior at school. There is the occasional abuser of the dispenser of the drug at the school. And what they will do is that instead of giving the child the medication, they keep it for themselves and may give the child an aspirin or something of that sort. And of course the children then will do well. And mistakes can be made, assuming that the medication is not working or the doses is not adequate and so on. Children are well covered when they are on a 12-hour medication to be able to do homework. Adults don't have to be carrying pills with them and remember to take them, which is not easy for many people. They forget. ADHD adults tend to be forgetful, which can create problems at work, home, and everywhere if they have to remember taking the second or third doses. Because if they forget, of course, there'll be problems in their behavior, their capacity to work, their attention, their irritability, and so on. Many of the formulations that are used as medications for ADHD do not last more than 5.5 hours, though they are frequently marketed as whole-day medications, which is simply not true, and you need to be very, very aware of this. Otherwise, things will not be resolved appropriately. So that's not true, except for Stratera, that is effective only, in my experience, in 30 or 40% of the cases. Decreased libido can cause priapism more frequently than methylphenidate and the like. So Stratera is supposed to last 24 hours. As I said, there are all kind of problems with it, and it's only effective in a limited number of people. Some new knowledge and new explanation. All the studies continue to show that ADHD adults have an elevated prevalence of substance use disorder if they don't take medication and not appropriately treated since early on in life. Alcohol abuse or dependence have been found in 17 to 45% of people with a disorder, while 9 to 30% have histories of drug abuse or substance use dependence. A study by Wiedemann and collaborators show that adults with ADHD have a risk of substance abuse disorders which is twice as high as people that don't have ADHD. The risk for ADHD patients treated with psychostimulant goes down to the norm for the United States, that is about 12% of substance use disorders, which is the norm for the whole population, so it's very effective in this regard, the treatment. The biggest jump in the use of ADHD medications, a 19% increase since 2004, has taken place among adults in the age group of 20 to 44 years of age. The increase in the group of 10 to 19 years was only 2%. The use of psychostimulants in children under 10 years of age fell actually during this period by about 5%. The total number of children 19 and younger in the United States taking attention deficit hyperactivity disorder medication is figured to be about 3.3 million. The total number of adults taking ADHD medication is assumed to be between 1.5 and 1.7 million. Now there is, let me make a reference to the transdermal delivery system. The patch is a patch and was approved by the Federal Drug Administration years ago in April of 2006. The size of the patch is variable and determines the amount of drug that will be delivered. The patch has a transparent backing and is known as dot matrix system. The methylphenidate is loaded in dots in the silicone layers that leave much of the silicone free to adhere to the skin. The patch should be applied only once a day. It delivers a constant amount of methylphenidate while attached to the skin. It needs to be applied 2 hours before effects are desired. It takes 2 hours to deliver enough medication to control the symptoms. It has to be removed in 9 hours for a 12 hours effect, or remove earlier if you want a shorter effect. The drug is delivered transdermally, as I mentioned, thus passing through the skin directly into the bloodstream, which means that more drug may be available, particularly of the L enantiomer removed by the liver to reduce symptoms. Thus, more of the L isomer circulates in the plasma than with oral medication. This, of course, leads to the question of is less medication than necessary, but this is still not yet quite clear if that is the case. Then you have the patches of the medication, which is called the Trana in the United States. As you see, it comes in 10, 15, 20 and 30 milligram patches. Here you have the size of the patch surface area, what the patch delivers. The methylphenidate dose delivered over 9 hours of wearing the patch. So you can see the information in that slide. Now, this system of the patch is particularly useful for patients who have swallowing problems and may allow in some patients for better control of the time of action of the medication. This is true not uncommonly of children that may have difficulties to swallow and or may tend to chew on capsules which may destroy the effect of the medication and so on. Effects are independent of the gastrointestinal content, so given that it is a transdermal patch. The side effects are essentially the same of the oral products. Insomnia with the original 12-hour patch was a big problem when this started. The Federal Drug Administration requested reduction to 9 hours for that reason. Sensitization to the patch is possible, that is, an allergic reaction might then extend to oral forms of methylphenidate. Is an open question if that could happen when sensitization to the patch takes place. The patch is applied to alternating areas of the child hips or thighs. In the provocation studies, applying patch in same place constantly led to a 13% of patients who develop sensitivity to it. Redness is common, but if edema, papules, or vesicles appear, a determination by the dermatologist is needed to ascertain whether sensitization has taken place or not. The patch has been studied only in children for 6 to 12 years when it was produced. Should be applied early in the morning. As I said, the effects will take 2 hours to start. Should not be worn for more than 9 hours, as mentioned, because the effect lasts for another 2 or 3 hours after the patch is removed. Should not be used with MAOIs. In fact, if somebody is on this medication, they need a 14-day watch out before they are put on the patch. The oral system, which is the system of the medication called Concerta, has an immediate release pad of 4, 8, or 12 milligrams for the doses of 18, 13, and 54 milligram capsule, so it becomes effective immediately. In my experience, the above amount seems enough for most patients in terms of immediate release needs. In rare cases where that is not so, a small immediate release doses may be added to the capsule or Concerta. The smaller patch should be used first, 12.5 centimeters, 10 milligrams for a week. And if the response is not satisfactory, the patch size and doses needs to be increased gradually every week until a good response is obtained. The erythema produced by the patch may not disappear until 8 hours after the patch is removed. Remember as well that there are formulations of methylphenidate in liquid form and even chewable tablets that may in many cases be an appropriate solution for the children that may have difficulties with swallowing. Other drugs that have been considered is modafinil, known as Provigil, approved effective for attention deficit hyperactivity disorder, but was not approved by the Federal Drug Administration due to safety concerns. It was going to be marketed as Spalron. Provigil is used at present in narcolepsy, sleep apnea, and the like. In the clinical trials, modafinil was associated with 31 cases of suicidal aggressive or psychotic behavior as well, and this is dangerous and important, or suspected cases of Stevens-Johnson syndrome that, as you know, can be lethal. A long-acting version of guanfacine alpha-2 adrenoceptor agonist is being considered, or was being considered for a while. A non-stimulant drug has been used as clonidine in the treatment of some aspects of ADHD for a long time. The results of it are questionable. So that concludes the lecture on ADHD and comorbidities. For any further information about the Carter-Jenkins Center, visit our website at the address that is given in blue in this slide. And there you can see the large number of programs on mental health and other issues that are available. If you have any questions, please address them to me. Thank you for your attention.